from Brent Green Party. I'm an officer and candidate. Thank you very much for giving me the opportunity to talk tonight. Since February the 1st, the Urgent Treatment Centre at Central Middlesex Hospital doesn't operate anymore between 9 p.m. and midnight. This is a significant change. The patients were not informed about it before the hours were reduced. Personally, I found out about the new opening hours thanks to someone posting a photo on Facebook on February the 2nd. I think you will agree with me that this lack of communication ahead of the new opening hours is in itself very bad practice from London North West University Healthcare NHS Trust. It is, however, entirely consistent with the consultation carried out by the Trust last October. It was very short, a couple of weeks at best, as I remember it, and it inevitably resulted in a very meagre number of responses from patients. Only 42 people took part in it. This is a stark contrast with the 570 signatures gathered by petition on the council website at the start of this year. There should be much more to say about the decision in itself and its impact on people. The NHS Trust is encouraging patients to access the pharmacy and their GP practice as a form of mitigation to the loss of the UTC late evening service. I found one pharmacy open until 10 p.m. within 2.5 miles from my house. As for accessing my GP, well, allow me to say one word: patches. Every time I need to use this form, I feel like I'm being cross-examined by a barrister for a crime I haven't committed. To conclude, I'm here to ask one thing to your committee: to remind the NHS Trust for North West London of the standards expected from them by patients. The NHS is there to serve patients and shouldn't try to make significant changes to our services behind our backs. It's a simple ask, but an important one, and I count on you to follow suit on this. Thank you.
Thank you very much indeed. We are grateful to you for joining us.
We have 3 urgent care centres, one at Ealing, one at Central Middlesex, one at Norfolk Park. The one at Central Middlesex was open until midnight. In that time, between the hours of 8 o'clock and 12 o'clock, we saw no more than 4 patients in that time period. So very small numbers of patients using it in them timings. What it meant is when you have a staffed unit open, you have to have a minimal amount of staff in that. For us, is 1 doctor and 2 nurses in that time. It was quite inefficient. The other concern was that we didn't have access to radiology services, and the majority of patients coming to an urgent care centre need an X-ray as minimum for their diagnosis. So we were having to send them away and bring them back the next day, or send them to Norfolk Park or Ealing, whichever was their closest. So it was a disjointed pathway anyway for patients in that time. What we knew that we had a higher demand of activity at our Norfolk Park site, so most Brent patients were already using Norfolk Park as their urgent care centre in that time. As equivalent to the 4 patients, we're seeing between 40 and 50 patients on the Norfolk Park site in them hours, and then patients were having to wait quite a long time to be seen because we had to reduce, we didn't have enough staffing in there. So what we chose to do is move the staffing from the Central Middlesex site to the Norfolk Park site so we could meet the demands of the patients where they were choosing to go, and we could see them in a timely way. What I'm pleased to say, that has worked perfectly as we planned. We've now got 100% compliance in terms of patients on the Norfolk Park site in that time being seen within 4 hours of attending to treatment and discharge. So it has had the expected impact, which I'm positive to say. In terms of engagement, we held 2 public engagement events. One of them was in person, one of them was online, because actually a lot of people do access online now. I mean, some people choose to come in person, but it seems to be more accessible to do them online. We also sent out our questionnaire. Our questionnaires went out through all of our patient channels, that we've got thousands of patients linked on them, so we get good engagement through our patient channels. And we found that the majority of patients came back to us and said it would have minimum impact on them, and many knew that they would already use Norfolk Park or Ealing sites part of ours anyway. We also looked at the people that were attending in them times, and what we found is, we're not saying that patients needed to go to their GP then, but the majority of attendance could have been dealt with via GP or pharmacist in working hours, so they didn't need to be seen urgently. Urgent care is very different to a GP or a pharmacy attendance. So there is some work we're doing around supporting patients to understand how and where to access services in working hours in terms of pharmacy and GP access as well. But all in all, the transition's gone very smoothly. We've had no complaints from patients. We've had no one mistakenly turn up and have to be rediverted. The communication has landed well with patients, and we positively have been able to see the higher demand of patients on the Northwood Park site within the right time frame and give them a better quality of care.
Thank you very much indeed. Great for you, Pippa. I'll take some questions if that's okay now, colleague. So I've got Rochelle. Rochelle, good evening to you. Your question to Pippa, please.
Yes. Thank you very much indeed for addressing the committee. I've got several questions actually. The first one is the significant change and the further reduction from last year. And also the distances between the three hospitals. I'm quite aware how long it takes to get from one hospital to the other. And you must, I mean, even though it's in the evening, you're not going to get so much traffic, but even so, it's quite worrying, particularly if somebody's had a stroke, because you need urgent treatment, obviously. And I know that the capacity from, not my own experience, but from several friends recently, particularly in the winter months, there's a significant number of people that need to be triaged, and a lot of people were actually waiting in the corridors. It was quite astonishing, really.
Thank you for those points. Pippa, please.
Yeah, so just to be clear, if someone was having a stroke, they wouldn't be in an urgent care centre. They'd go into our UEC emergency care pathway. So an ambulance wouldn't take any patient to an urgent care centre, and patients wouldn't attend. If someone was having a stroke, they'd call an ambulance, they'd go to an A&E department. That's different to an urgent care centre. An urgent care centre is where we see minor illness, so similar to a GP. So minor illnesses, they tend to be simple fractures. Frankly, people turn up with colds and coughs and respiratory illnesses. That's what's seen in an urgent care centre. It's very different to an A&E department. The important thing about distance is communication getting to the patient, so that what we were doing is, because we had the service open, some very small proportion of patients were coming and we were having to send them to another unit. That is a wasted journey. We need them to go to the right unit in the first place where they can be seen with all the pathways open.
Thank you for that. I'm going to ask Charlie for his question next, please. Charlie, good evening.
Good evening. I have a few. I'm going to start with this one, which is, I think you just illustrated one of the problems I have with this, and I'm going to speak from my own personal experience. I woke up one morning in October with my eyes pointing in the wrong direction. One was pointing that way, one was pointing that way. I went to the nearest hospital, which was Middlesex. I had no idea there was no A&E there. You've just said, and actually, I'm going to add the point about stroke. The symptoms I had, and it recurred later that day, and then when I saw another doctor at Ealing Hospital on Friday, could have been a stroke or a TIA. So your assumption that people are not going to these places because that's not where they're supposed to go is based on the assumption that they know where they're supposed to go in a medical emergency. I didn't, and I'm a counsellor. So that's the first one. It touches on my broader issue with this whole point, which is you just sort of said that not many people are going there after hours, and actually most of them would need to be redirected anyway because they need the scans, etc. Which begs the question, why did we shut the A&E in the first place? Right? Because I had to go to, on the following, later in that week, having then been redirected to Ealing Hospital on the Friday for a follow-up appointment. I was then sent to Northwood Park. I was referred into Northwood Park by A&E. They were expecting me. I still had to queue for 20 minutes outside the door before I was even in the building. The whole experience, when by the way, I had just been told that I might have had a TIA and I was high risk of a stroke potentially, and I might actually need to be admitted to hospital. I'm standing outside waiting in a queue, and then I'm waiting another hour before I finally get actually seen by the person I was referred to. So they were expecting me, and it still took ages to get through. And that just begs the question, why are we so determined to send everyone to Northwood Park? Spreading people out so that there's better access seems to be much more practical. So that's the kind of crux of my question, which is, are we actually happy that this is working? Because it does not feel like it's working from a patient's point of view.
Okay, thank you.
So I think there's a couple of things in there. So there is a national promotion. I think we've all got to do more to promote it is the talk before you walk. So it is very much you dial 111 and 111 will tell you where to go on symptoms, and we're really pushing the talk before you walk so people don't waste a journey going to the wrong. You know, I do accept across the country A&E models have become quite confusing actually, and that's why they're really pushing the talk before you walk, so you can get the right clinical advice on the symptoms that you're describing, so you are diverted to the right site in your locality to go to. And I think we need to do more to help people understand that pathway, because it's the most efficient way of getting to the right place at the first time. The whole national programme around what you're talking about is the stroke pathway. It's a national initiative. It many years ago was implemented. It has significantly improved the stroke care for patients, significantly. But that can only be done in centralised places. It's quick access to things like removing clots, unblocking arteries and things like that. You cannot possibly do that on every site. You can't. We don't have the expertise. We don't have enough people trained. We don't have enough equipment, and you have to have a big resource of people on a site to do it. And the whole national agenda of putting stroke sites into networked approaches has significantly, we've got all the evidence, significantly changed the outcomes for patients. It's just helping people access and know where to access with the right symptoms. So it does come back to we need to be encouraging people to dial 111, to explain symptoms, and they will divert them to the right place at the first time.
Thank you. Kanta, please.
Thank you, Chair. Thank you for the reports. I can understand the residents' and patients' worries and concerns. What I'm trying to aim at is this financially driven? Because once an organisation like the NHS embarks on a reduction programme, which is what's happened in this case, I understand what you're saying about only 4 patients or 5 patients in that short time that you've reduced. I think the fear from residents and local people sets in that eventually it will just disappear. Now, I know what the Central Middlesex does other than the urgent treatment system, because I have family members who get treated. But what guarantees are there? I know you're probably not going to, but that this might be the case, that eventually the whole treatment centre will disappear, and a reduction in hours, and that it may not be anything of development or something. So what guarantee can you give to us?
Thank you for that good question, Kanta. Grateful to you. Pick up, please.
Thanks. So I think what I'd say is Central Middlesex as an entirety has more services in it than it's ever had. Like, we have moved so much there, and it's a fantastic, I mean, it's one of our best hospital estates across most of London, actually. So, and we've put so many elective and specialist services in there now. It's got the new community diagnostic centre, it's got the new endoscopy suite in there. It's got so much in it now. We're using that maximum facility that we've got. In terms of an urgent care centre, we haven't done this for money. We've done this to move the resource where the patient demand is. If we'd have taken it out to save money, I think that's a slightly more challenging question to me. What we've done is move the resource to where the patients are. These are all patients in Brent. Norfolk Park is also in Brent, and patients from that area were choosing to go there because they know it's open 24 hours a day. So all we've done is move the resource to where the patients are. And we do have to do that. I have to do that in a lot of my services where patient flow is. I have to move my workforce to be able to meet that.
Thank you, Pippa. Catherine, please, and then Tony, and then if you have time, I'll come to Charlie.
Thank you, and thank you very much to our speaker. I'm sorry I didn't catch your name, for coming to speak to us about this. We've picked up a lot of your points as we've been talking, but there's one thing that you said that I don't think that we've discussed. I think you said that, was it 45 or 46 people were involved in the consultation, which you said, you know, there were opportunities to do that, but that seems really tiny, thinking of the number of people who must be served by Central Middlesex. What could have been done to make it so that there was a higher response rate on the consultation? Because it must affect people on lots of different levels when the provision is changed. So what can we learn from that incredibly low rate of response to the consultation?
Thank you, Catherine. Pippa?
Yeah, I mean, I think there's always more we can do to engage. We have to work at certain time frames, and I really needed to make this change happen before winter was at its busiest, because I needed to move the demand to deal with the patient demand in winter. But I mean, we engage fully through all of our communication channels, which actually are usually really proactive channels that communicate back with us. We've got some very, very strong patient user voices which cascade all our messages. You know, I think we could have worked differently with local authority and ICBs, but this wasn't an ICB change, so that, you know, the ICBs will communicate through their channels wider when it is a wider system change, but this was a local change. But you know, there is always more we can try and do to communicate. It's different changes generate different responses, and I generally think it's because there was such a low usage in them times, it impacted such few people. Whereas when we've communicated out, let's just say sickle cell, which is a much smaller population, we've had huge responses back. So it just depends on what you are changing.
Thank you. I'll come to Tony now, please.
Thank you, Chair. Yeah, thank you, Pippa. You've answered some of my questions. In fact, there's overlapping questions that I had, and yeah, some of them have been answered. But I still want to go back on this this consultation as to whether it was comprehensive enough in terms of the number of people that have actually been consulted and responded to this. Also, I understand from the data I've received that there was a petition that had 570 people requesting that the hours are not reduced. Whether that was taken into consideration, I don't know, given the level of respondents to the consultation. So that's something that maybe should have been also looked at, and I'm not sure that that was actually done. The other question is in terms of the equality impact assessment, which is fundamental to any sort of assessment regarding policy and changes, is whether you've taken into account, given the COVID experience, whether you've taken into account the composition of people that might need the urgent care centre. Okay. The south obviously is more deprived than the north of the borough.
Thank you.
I don't know if that was taken into account.
Okay, Tony, I'm going to pause here so you can get the answer, because we've got very limited time before we break for the fast.
So just to be clear, it's not a formal consultation. It doesn't meet the needs of a formal consultation. It's an engagement. It's a minor change to a service. There's like NHS rules around what constitutes a formal consultation, what's engagement. So engagement, like I've just spelled out, happened. We took the written results, we took the feedback from the face-to-face and virtual feedback and consolidated all of that. The petition didn't come till after we'd made the change, so that was quite difficult. I mean, we started the engagement in October, we changed the hours of the service in February, and the petition came after that. So clearly we knew about it, the change had happened and the staffing had been moved by then. What I would say is we haven't, I wasn't aware of the, until February of the petition. What I would say is we continue to monitor it, and I haven't had a single complaint yet, I haven't had a single clinical issue. What I have had is positive in terms of the number of patients we can see more efficiently in that time frame.
Thank you.
Sir, the petition came before the reduction in the hours.
Martin, thank you. Charlie, please.
Yeah, I just want to quickly follow up on the previous point, because I think we got slightly sidetracked because I used my example. The real question was, I accept what you're saying is, having closed the A&E, the usage of Middlesex after those hours was not great, and you were having to redirect people to Northwick Park anyway. My point was that Northwick Park is famously completely, insanely rammed. And my question is, why are we not reconsidering effectively having 2 A&Es again? That's the point, and I'd love to see, and this goes to the point that we've talked about, and I know you're looking at getting this report for us, holistic service provision across the borough. What do we have the right facilities in the right place, rather than looking at these things on an individual basis? Because in the context of this specific small decision, I accept your logic probably does make sense, but the impact is that it's been the gradual reduction of these key services that people don't plan to go to, and that's the crux of my question.
Thank you. Very briefly, please.
Yeah, I would just say that's a bigger London piece. So you can't look at A&Es like you've just said. I have three urgent care centres in my trust, but you have to look at the whole A&E across London landscape to be able to do that, and that work happens all the time. You also have to look, as you know, at the ONS data and where the population's moved to, and we know the population's moved to the outer boroughs from the inner boroughs. There's been a whole change in the last few years of higher population moving to some of the outer boroughs, hence why population growth has happened in Brent and in Harrow. So we have to factor that in when we're planning our services, and that's what we've just done in terms of the additional capacity we've put in at Norfolk Park in the last 2 months to be able to manage some of that demand.
Thank you. I'm going to bring this to close. If there are any other questions, then get in touch and we'll get people to answer. And we'll make sure that the replies are within our pack for the next meeting. But I'm going to bring this to close. But before I do bring this to close, are there any recommendations that you want to make to this particular item? Tony, please.
Yeah, I was wanting to make a recommendation that we should review, the reduction in hours based on a more comprehensive consultation. It may not be possible, but if it is possible, that's one of the recommendations I'd like to make. Because in my mind, I think it's about reduction in terms of finance rather than looking at people's health.
Well, you heard the answer from Pippa quite clearly, but anyway, did you have your hand up for your recommendation?
Yeah, just to reiterate the point about that overarching report, like you talk about population growth, data, etc. I would like to see that and understand the big picture and if there are gaps, and a serious review of whether it is actually working.
Okay, thank you very much for that. We are grateful to you, Pippa, for your update on this particular item. While we have got you, Pippa, very briefly, and I mean very briefly, please, if you could just give us a quick update on the Northwood Park situation, Northwood Park pool situation and sickle cell situation, which you referenced earlier.
Okay, I don't think there's any further updates I can add, if I'm honest, around the hydrotherapy pool. It closed in August. We worked with local authorities and sports centres to try and provide facilities within local sports centres. That's been set up in 2 or 3 centres now around us, supported by some of our staff, but run by local authority, running council sports facilities, and patients are accessing that. We've also got the direct referral into Stanmore, which is working really smoothly. Again, no recent concerns from patients or capacity issues. So I don't think there's anything to update there.
Sickle cell, please.
Sickle cell, it's a progressive plan. It's been very positive. It's been designed by patients with large patient engagement of our cohort of patients, sickle cell patients from Brent. We've now got the 24/7 tertiary access centre open at Hammersmith, which is our haematology sickle cell specialist centre. Patients can phone there directly. Paramedics can take patients straight there in a crisis. So all patients now have access to a tertiary centre in the sickest conditions, and that's been open since January. We have now also just opened, which was phase 2, the dedicated sickle cell day service at the Central Middlesex site. We've had to move our medical day service out of that because what our sickle cell patients were telling us is they felt nervous coming there when we were sharing it with medical patients who quite often had infections and things, and they were coming for antibiotics, and to be fair, it's not an ideal pathway to share with a sickle cell patient. So we've moved our day medical service to Ealing, which is where the highest demand was actually, and we've now dedicated the whole day service at Central Middlesex to our sickle cell patients run by specialist sickle cell staff. So that's been really well received by that community. The third part that we've now got to deliver is we committed to having that open 7 days a week. It's currently open 5 days a week, and we'll progress through the next 6 months to get it open 7 days a week. And then I think we've got a complete, actually quite exemplary sickle cell pathway, rightly so, because we've got one of the highest sickle cell communities, but we've got a great pathway across Brent for them patients.
Pippa, really am grateful to you. I know how busy you are. Thank you very much for making the time to attend this evening's meeting at such a short notice and updating us on those 3 key services, which means a big deal to our residents in Brent. Thank you very much once again, and we look forward to having your company next time. Thank you very much. Friends, we're going to pause.